Here's the thing. They did. This needs to be addressed immediately because the premise embedded in the question, while useful as a starting point, contains an assumption the historical record does not support. Ancient Romans washed before meals as a matter of social convention, so established it was practically unremarkable. Islamic religious law codified ritual hand-washing before prayer more than 1,400 years ago, creating a consistently practiced hygiene program on a global scale. Jewish law required washing at multiple specific points in the day, with dedicated blessings attached to the practice. Ancient Egyptians used preparations of animal fat and plant ash, functionally soap, as a regular part of personal cleanliness. So the more accurate and considerably more interesting question is this. Ancient humans washed their hands constantly for reasons that had nothing to do with preventing infection, and this created a remarkable situation where genuine pathogen reduction happened entirely by accident, while the mechanism that made it work remained invisible for most of human history. To understand this, you need to understand what ancient people actually believed about disease causation. The idea that invisible particles from a sick person or contaminated surface could transfer to another person and cause illness is not an intuitive one. It required technology, specifically the microscope, to observe directly. Before that technology existed, the dominant explanatory framework for infectious disease across most of the world was miasma theory. The idea that foul-smelling emanations from rotting matter, sick people, or polluted environments produced disease through bad air. This theory was predictably useful while being mechanistically wrong. Disease was genuinely more common near swamps, near sewage, in crowded environments, and less common in clean and ventilated spaces. Miasma theory explained the pattern correctly. It simply misidentified the cause. This is worth pausing on because it illustrates something important. A framework can generate accurate predictions about where disease occurs without correctly identifying why it occurs. Within this framework, hand-washing had a logic. Bad smells were associated with bad air, which was associated with disease, and washing removed bad smells. So washing was connected to health, but through an atmospheric rather than a direct contact mechanism. Hand-washing specifically, as distinct from bathing generally, did not occupy a privileged position in ancient hygiene thinking for this reason. People washed because it was socially expected, because religious law required it, or because it was personally comfortable. That it was simultaneously interrupting fecal-oral pathogen transmission was, from the ancient perspective, incidental.
The ritual dimension of ancient washing behavior is genuinely important and frequently underappreciated. Ritual purity systems appear in some form in virtually every major religious tradition, and they created extensive regular washing behavior, justified entirely in spiritual rather than hygienic terms. The Jewish concept of tuma required washing in specific circumstances, before eating, after toilet use, after certain categories of contact. The Islamic practice of wudu required washing hands, face, and feet before prayer. Hindu ritual bathing before religious observance created consistent hygiene practices within specific communities. Buddhist monastery hygiene codes were sufficiently explicit about washing that they have been cited by historians as contributing to lower disease transmission in monastic settings. None of these practices were understood as germ prevention. They were understood as spiritual disciplines, maintaining ritual readiness, removing religiously significant states of contamination. But the behavioral result was the same, regardless of the framework that motivated it. Regular washing happened to remove pathogens. This represents one of the more interesting cases in the history of medicine. A practice that worked preceded the understanding of why it worked by thousands of years, and that understanding, when it eventually arrived, did not add to the effectiveness of the practice. It only changed the justification. The single most consequential moment in hand-washing as a medical intervention is worth examining in detail because it illustrates how slowly evidence can change practice, even when that evidence is unambiguous. Semmelweis was a physician working in Vienna in the 1840s who noticed a stark difference between two maternity wards in the same hospital. The wards staffed by doctors and medical students who came directly from performing autopsies had maternal mortality rates of 10 to 15%. The wards staffed by midwives, mortality rates around 2%. The difference was severe enough that women forced to enter the first ward sometimes chose to give birth in the street rather than be admitted. Semmelweis concluded that doctors were carrying something from the autopsy room to the maternity ward on their unwashed hands. He implemented a hand-washing protocol using chlorinated lime solution, and mortality in the first ward dropped to match the second. He had demonstrated that hand-washing prevented lethal transmission without knowing what was being transmitted or how it caused disease. The response from the medical establishment was largely hostile. His evidence was dismissed. He was eventually committed to a mental institution, where he died of the same category of infection he had spent his career trying to prevent. His hand-washing protocol was discontinued after his departure. The Semmelweis case is not simply a story of ignorance resisting evidence. It is a story about the psychological dynamics of accepting evidence that implicates the people evaluating it. Accepting Semmelweis required physicians to accept that they were killing patients with their own contaminated hands. The professional and psychological cost of that acceptance motivated finding reasons to reject the evidence rather than accept it. Evidence alone, without a mechanistic theory to make it comprehensible, proved insufficient to change established practice. Germ theory, developed in the following decades, provided that mechanistic theory. Once Pasteur and Koch established that specific microorganisms caused specific diseases, and that these organisms could be killed by appropriate interventions, the framework existed that made Semmelweis's findings comprehensible in retrospect. But translating scientific understanding to population-level behavior change required more than theory. It required infrastructure. Running water, soap, and appropriate facilities for washing were not universally available for most of human history, and they remain unavailable to a significant portion of the global population today. Current estimates place over 2 billion people without a basic hand-washing facility with soap and water. For these populations, the barrier to hand hygiene is not knowledge or motivation, it is physical access. This matters for how we interpret ancient hygiene behavior. The medieval decline in hand-washing practices in Europe after the collapse of Roman infrastructure was partly a story about the loss of water systems that made regular washing practically feasible, not purely a story about knowledge or motivation declining. When Roman aqueducts failed, the public fountains and bath complexes that made washing convenient disappeared with them.
What ancient washing actually prevented and what it did not is where the picture becomes genuinely interesting. Washing hands before eating, practiced across cultures for reasons of ritual and social convention, interrupts the fecal-oral transmission route that spreads gastrointestinal pathogens, including cholera, typhoid, and hepatitis A. Cultures with consistent pre-meal washing practices would have had measurably lower rates of these specific diseases through a mechanism no one involved understood. But many of the major historical killers, plague, smallpox, typhus, malaria, travel through routes that hand-washing does not address. Plague spreads primarily through fleas, smallpox through respiratory droplets, malaria through mosquito bites, typhus through lice. Populations with exceptional ritual hand hygiene were not meaningfully protected from these diseases by their washing practices, which explains why cultures with high hygiene standards did not necessarily show dramatically lower overall mortality. The modern hand-washing movement did not invent hygiene. It provided the mechanism that explained why practices already in place for thousands of years were preventing exactly the diseases they were preventing, while clarifying why those same practices offered no protection against the diseases that killed most people throughout most of human history. Ancient humans washed their hands constantly. They simply had no idea what that was doing for them.